Good afternoon, everyone, and welcome to NHMA's Salud and Policy Town Hall, Vaccinations Across the Lifespan. Thank you all so much for joining us today and for taking the time out of your busy days to be a part of this important conversation. Before we begin, I just wanted to start with a few housekeeping items. Today's town hall is being recorded and will be shared on NHMA's website and YouTube channel. Also, please submit questions at any moment using the Q&A feature. And then lastly, we'll reserve time at the end for discussion and also some audience questions. For those who are not familiar with the National Hispanic Medical Association, we are a nonprofit organization representing over 50,000 licensed Latino physicians nationwide, and our mission is to empower Latino physicians and other underrepresented healthcare professionals to improve the health of Hispanic and underserved communities through leadership, development, education, policy, and advocacy. And now, today's conversation we'll take a live course approach to vaccination, and we'll begin with public health data, then move on to maternal health and family medicine and some policy perspectives. And each one of our speakers will have about 10 minutes to give a presentation, followed by a Q&A. And so, without further ado, our first speaker, Dr. Luján Soler, who will ground us in the latest COVID-19, influenza, and RSV burden vaccination coverage, including some disparities that are impacting Latino communities. She will also highlight some evidence-based communication and strategies, as well as some community-driven approaches that strengthen vaccine confidence. So, Dr. Soler, I will now turn it over to you.
Okay. Thank you so much for inviting me to present today. So next, please. We all know how SARS-CoV-2, influenza, and RSV are major contributors to global respiratory illness across all ages. Of course, those that are older than 65, younger than 5 years of age, and those with high-risk medical conditions suffer the severe consequences of this disease. And preliminary burden estimates in the United States show that these viruses cause millions of outpatient visits each season, 100,000 of hospitalizations, and tens of thousands of deaths. So a really important burden. Next, please. So we have vaccines available for the three these diseases of course, to protect against severe consequences of the disease. And the science is with us, and updated evidence continue to support that vaccines continue to be safe and effective. And this was published recently in the New England Journal of Medicine. Next, please. But despite having these available vaccines that are safe and effective, we see that vaccination coverage the numbers are not ideal. In this graph, I show the COVID-19 vaccination coverage for children and adults as of January 2026. As you can see, adults have a vaccination coverage of 17.3%, and children only 8.3%. Next. And when we look into vaccination coverage by race and ethnicity, you see disparities, and Hispanics lags the rest of the population, only 9.4%. Next, please. And looking into influenza vaccination coverage, adults also show 46.2%, children 45.4%. Just recall the target goal for influenza vaccination is 70%, so we are below the goal. Next, please. And disparities also show that Hispanics have lags with a 37.4%. So we are all below the goal. Next, please. And RSV vaccination, we have the vaccination for those that are 75 and older universally, and 42.8%. vaccination coverage, and those that are have indication that are 50 to 74 with high-risk conditions, only 32.2%. And disparities also are shown in those 50 and over. Next, please. So the infant protection against RSV can be acquired in two ways: by maternal vaccination and through the recipient of RSV monoclonal antibody to the baby. This graph shows information from the National Immunization Survey drawn from respondents were females, 18 to 49 years of age, that have an infant less than 8 months of age, doing a RSV for the RSV season. As you can see, as of December, 53% of infants received the RSV monoclonal antibody, and 7.3% the mother received the RSV. So 60% of infants were protected one way or the other. Next, please. Next, please. So it's important to understand the reasons why people don't get the vaccine, or which are the motivators, or which are the concerns. So these are shown also from a national immunization survey from the CDC. The main motivator to get this COVID-19, RSV, and influenza vaccines by the respondents, the main motivator they mentioned was to protect themselves, and only 1/3 the main motivator was to protect others. So herd immunity should be included in our education too. And the concerns varies among vaccines. So we believe that many people are pro-vaccine, but some vaccines we need more time to explain and different specific points. For example, for the COVID-19 vaccination, respondents indicated that they were concerned about the severe consequences of the vaccine or severe adverse events. For the flu, 18.4% were more concerned, not concerned about getting the flu. So risk perception was low. And regarding the RSV vaccination, less information. They don't know much about the RSV or the RSV vaccination. And half of the respondents have no concerns or issues talking with the RSV vaccination or influenza vaccination. And only 30% have no concerns on the COVID-19 vaccination. So they are more confident or they accept more the first two vaccines comparing to the COVID-19 vaccine. Next, please. So every year we do a vaccination campaign in the Hispanic community in Latin American consulates in the waiting rooms. And this data is shown because we did a survey study. And the main reason why people don't want to receive the vaccine is because they have fears. And the fears are fears to adverse events and fears to needles. And the specific fears to adverse events, what I want to point out first of all, well, they are afraid of the pain at the injection site. They don't want to get pain. And also fear to get sick after getting the vaccine and maybe being unable to go to work, miss work because of getting a vaccine. Also, of course, fears to get sick from the vaccine for the flu. And also something that is very, very, as we've been doing this for a long time, this specific year, people were more afraid to provide personal information because of the immigration enforcement. So it was really challenging to offer the vaccine and then to accept the vaccine because of fears of that kind. Next, please. So our experience is that large communication campaigns and large mass communication channels are really important. Social media and all more massive educational campaigns are important. That will raise awareness in the community about the importance of vaccination, but we strongly believe that we need to change people and make the vaccines more confident to the patients. We need to be a more target-oriented vaccination campaign. So we really believe that a trusted messenger is key. Anyone can be a trusted messenger. Of course, healthcare professionals are key messengers, leaders from organizations or from the community, but also family members or anyone in our family, in our work can become key messenger and trusted messenger. So when we educate, we can educate everyone, not only those that don't believe in vaccine or are more hesitant. I think we need to empower also those that really believe in vaccine and the power of vaccines, and so that they help us raise the voice. And do the education in a familiar setting. For example, the consulate is a great place because it's a place where they share the same language, they share the same culture, and they feel more confident. Also having vaccines available at the same time, so we don't miss the opportunity to vaccinate, also is really important. And if we don't have the possibility to having the vaccine available, at least having that information on hand to guide them where to get the vaccine. So what we do is we provide a more general introduction about the importance of vaccination, but being very clear on the recommendation. Now we have some confusing recommendations, but it's very important to highlight that, of course, everyone needs to get vaccinated and specify those high-risk groups. And one-on-one education, we usually approach one-on-one. We listen to what the person have to say. So we need to understand and identify their concerns, find a common ground, make it more personal. I'm a mother, as you are. I need to stay healthy for my kids. So it's really important to start on the same base and respond and very specific and be honest if there's an adverse event that is real. Vaccines are not perfect, but it's the best way that you can do to protect yourself, and benefits outweigh any risk. Stories also are really important. If you share it, they help. And after that intervention, what we do is we offer printed materials, but targeted to the population that we are talking with. If we go to the consulate, of course, needs to be in Spanish. If we go to colleges, well, the immunization schedule should be targeted to the ages that we are approaching. So I think that will help. Next, please. So next, please. So science is with us. Next, please. So that didn't change. Public support is strong. So some specific vaccines, maybe people are more concerned with, and we need to spend more time and identify the specific points of hesitancy. Everyone can become a key messenger, so educate everyone. Communication strategies might include mass messaging, so that we raise awareness as a community. But personal and target-oriented messaging is that it will make change that confidence on vaccines. Next, please. So a culture of vaccination grows with informed voices. Next, please. So just a final message. Personal messaging builds trust where mass messaging can't reach, and together they reignite a culture of vaccination. Thank you. I'm sorry I had to rush, but I know that I had so little time to spend. But if you have any question, I'm open to answer. Thank you.
Thank you so much, Dr. Soler, for setting the foundation with both the data and the practical strategies that can help move the needle. Next, we'll hear from Dr. Laura Ramirez Caban, who will provide the clinical maternal reproductive health perspective on vaccination across pregnancy, early infancy, and beyond. So Dr. Ramirez Caban, I'll now turn it over to you.
Thank you all. I'm very excited to be here and talk on a topic that's very near and dear to my heart, which is taking care of my patients, my female patients. I'm an OBGYN. Full disclosure, I no longer practice obstetrics. I'm a gynecologist only, and I specialize in surgery, specifically fertility surgery. So the patient population that I see is a lot of young patients that are seeking to get pregnant, or they've been pregnant in the past. And there's, especially with our current climate, not to get into too much detail, we've had a lot of recent changes with those vaccinations, and this topic comes up frequently in my office. Next, please. So vaccinations, we're going to be talking today about vaccinations within pregnancy. Next. We're also going to be talking about vaccinations in non-pregnant patients. Next. And then we'll talk about we'll touch briefly on early infancy vaccinations as well. Next slide. So vaccinations in pregnancy, we have a few that are recommended, and they're specifically recommended. The first one's going to be the flu vaccine. You can keep going, Ashley. They have several animations, so you can just keep going and then we'll read off. But the flu vaccine basically is, it's recommended every single pregnancy. For the mothers, even if they've had it in a prior pregnancy, we recommend it yearly and in any trimester. And typically we recommend it right around the time of the flu season. Pregnant patients particularly are at risk of having adverse outcomes with the flu, higher rates of ICU admission, pneumonia, just because their body generally is immunocompromised in the state of pregnancy. It's also recommended that anybody that's going to be around the pregnant patient, or at least have contact with the infant, with the neonate, also be vaccinated against flu. The second vaccine that's recommended is also is COVID vaccine. And this one, there was initially, when the COVID vaccination first came out, there was initially pregnant patients were not included, but multiple studies have been conducted since, and the COVID vaccination is very safe in pregnancy. And again, because of the state of immunocompromise in pregnancy, it is highly recommended for patients to have the COVID vaccine, specifically having a vaccine or booster each year. It can be giving at any trimester. There's no particular trimester where it's recommended. There's a lot of hesitancy in the first trimester as embryogenesis and the baby's developing, but all the studies have shown that there's no adverse outcomes with giving this vaccine even in the first trimester. You also want to get it at the earliest opportunity possible to maximize both maternal and fetal health, and the babies are also born with immunity once you receive the COVID vaccination. Tdap is another one that's routinely recommended every single pregnancy. Even if you received it, you were pregnant 2 years ago and you received it in pregnancy, we still recommend it every single pregnancy. And the reason is because of the pertussis component of this vaccine. Protection against this, we want in each and every pregnancy so that the baby gets a boost in their immune response, and they're born with some immunity towards the pertussis virus, the bacteria. So this is given every pregnancy. We typically start giving it between 27 and 36 weeks of pregnancy, again, to maximize that immune response. And it'll give the baby immunity up until 2 months of age. This is also a vaccine that's recommended for anyone that's going to be in close contact with the neonate in the first couple months of life. So any kind of close caregivers, any close family members, it's also recommended that they receive this vaccination to kind of have herd immunity for the baby. RSV is our new one, and I know we briefly heard a little bit about RSV as well in the prior presentation, but RSV is the latest and the greatest one. So Pfizer came out with this vaccine. It's called the Brisvo. That's the brand name of it. It is to be given in pregnancy, one time in pregnancy only. So unlike the other vaccinations, it's not given every pregnancy. It's just one time in pregnancy. And the stipulation is that if you will be between 32 and 36 weeks of pregnancy between the months of September and January, you're a candidate for this vaccination. And basically the idea is that we vaccinate mom and then the baby receives the immune response. So this provides immunity for the neonate, for the infant, up until 6 months of age. This is the one that, because it's newer, a lot of my patients have been asking about it. Should I get it if I become pregnant? Even some of my colleagues. I actually am pregnant myself. I'm 28 weeks pregnant, and even though we're going to be out of the RSV season, my maternal fetal medicine say, hey, if you want to pay out of pocket, you should get it as well. So it's been really nice. Next slide. And I did get it. RSV considerations we can go through. So there is an alternative. So basically, in moms that say, it's a newer vaccine, I'm not sure if I really want to engage in that. The baby can also get monoclonal antibody, and this is the nirsevimab that is given to infants. They can get it as soon as they're born, and typically is during RSV season between October and March. Like we said, if the mom has received the RSV vaccine in a prior pregnancy, right now the recommendations are not to repeat the dose in pregnancy themselves. But the moms can also have the RSV vaccination in the same time that she's having flu, COVID, and Tdap. She may have a bit of a reaction, but all 4 of these can be given at the same time. If the mom has tested positive for RSV, so say that it was January and she got, the RSV, she tested positive, but she's about to get the vaccine, later in the month of January, she can still be a candidate to receive this vaccination, even if she's already tested positive for RSV. Next slide. Side effects of vaccines in pregnancy. So this is a big one. Majority of patients end up with no side effects. It's totally fine. But some patients, about 10%, 10 to 20% of patients can have mild symptoms, usually resolved in 1 or 2 days. These symptoms are typically sore arm, low fever, low-grade fever, some headache, some muscle pain, and some nausea. And then the treatment for this, you can click next again, Ashley, is Tylenol. And Tylenol, we still recommend Tylenol. ACOG, which is our governing body for the American College of Obstetricians and Gynecologists, we recommend Tylenol in pregnancy. Multiple studies have been done regarding Tylenol in pregnancy, and autism does not show to be causative from taking Tylenol. So we still recommend it. Next slide. Side effects of vaccines in pregnancy. Oh, we did this one. Oh, maybe mild symptoms. And then the next one. One more time. Thank you. Vaccinations to avoid in pregnancy, you can click the next animation. Typically, we want to avoid live attenuated vaccines, and then these include chickenpox and MMR. And then it also actually includes HPV vaccines. This might change in the near future, but for now, we're still recommending that pregnant patients not receive HPV vaccine. What I will say about HPV vaccine, and we're going to talk about that vaccine next, is that it's not allowed in pregnancy, but in the postpartum state. So having moms, when they're admitted postpartum for those 1 to 2 days, if they had a vaginal delivery, or 2 to 3 days if they had a C-section, it's a great time to be able to capture that patient population to be able to get those young females vaccinated against HPV. So that's something always to consider as well. We're going to shift gears a little bit on vaccinations in non-pregnant patients. We're going to talk specifically about HPV. Next slide. So in HPV, we know that there's several different kinds of strains. The ones that we tell our patients is 40 strains that we've identified, but there's some studies that reach up to 100 different kinds of strains. We know that cervical cancer, over 70% of cervical cancers are actually associated with strains 16 and 18. This is considered a high-risk type. 45 also can do it as well, but more so 16 and 18, over 70% of cervical cancers are associated with these strains. Genital warts are associated with strains 6 and 11, and they're considered low-risk types and do not lead to cervical cancer. We have identified 13 other high-risk types, so a lot of the conversations in my office center around patients saying, hey, doctor, I never had HPV before, and all of a sudden I tested positive for HPV. It's because our test is getting better. We're able to see more of those tests. We're able to get more strains within our test. Additionally, we also know that HPV is a dormant virus that can remain dormant in your body and get reactivated at any point. Keep going, Ashley. You can just keep going through the animations. Spread is through skin-to-skin contact during vaginal, anal, or oral sex, and you can get HPV even if you do not have sexual intercourse. So I have patients that say, I've never had sex, I've only done, contact, kissing, hand things, whatever you call it, and they still are able to get HPV. The vaccination schedule, it is recommended for girls and boys ages 11 to 12, but the range is actually 9 through 26. Typically, any patients that are under the age of 15, they get a series of 2 vaccines, and patients above the age of 15, they get a series of 3 vaccines. There is a catch-up period, which is considered, it's 27 to 45, and this can be given to both male and female patients. Sometimes insurance won't cover all the way up to age 45. So I always recommend patients check, but usually the vaccination, you can get it at the doctor's office between $200 and $300 is what I usually estimate, but we can always check with your specific provider if you have a discounted price. Next slide. So HPV vaccinations, once a patient gets an abnormal pap smear, they need a colposcopy or a leap in my office with me. A lot of times patients say, what can I do to help prevent HPV, or what can I do to help treat it? And I always recommend the vaccination if they haven't had the vaccination in the past. The other questions that comes up is that the vaccination used to be a quadrivalent, so it was 4 strains that were included in the old vaccination. The newer vaccination includes 9 strains. The studies basically say if you receive the vaccination with 4-strain protection against 4 strains, you don't necessarily have to do the 9-strain vaccination, but every patient is individually different. And if they really want to do this and their insurance will cover it, or they're willing to pay out of pocket, I don't ever decline them that option. The other thing is we always also say no smoking for patients as well. We say it's quit smoking if you're a smoker. That makes HPV worse. And again, we typically avoid it in pregnancy. Next slide. Early infancy vaccinations. And I think this is my last one and it wraps up my 10 minutes. But hepatitis B vaccine, there's been a little bit of controversy regarding this topic. In recent months, you may have seen in the news, but the American Academy of Pediatrics does still encourage hepatitis B vaccination at delivery and at birth. Infants should receive their first dose of hepatitis B vaccines at birth and typically complete the series between 6 and 18 months of age. The birth dose is crucial for preventing long-term illness in infants and the spread of hepatitis B in the United States. Patients can still get the hepatitis B vaccine. We still offer it to patients on labor and delivery, despite some mixed recommendations. So patients can opt out of receiving the hepatitis B vaccine. We certainly recommend it in moms with chronic hepatitis B or moms whose status of vaccination is unknown. Or anyone that potentially is at risk of having hepatitis B, we strongly recommend that they get hepatitis B for the baby at delivery. But it's still offered at labor and delivery units just because of the benefits that it shows to the baby. And that's all I got. I have a slide. Next slide, I have a slide of references, and then any questions that we may have, which I think we'll hold to the end. But that's all I got.
Thank you so much, Dr. Ramirez Cavan, for outlining the clinical guidance on vaccination during pregnancy and early infancy, and for addressing the common safety questions that providers and families often raise, and especially now in this environment when there's a lot of confusion and misinformation.
Absolutely.
Thank you. So next we'll hear from Dr. Sara Ramirez, who brings a family medicine perspective to today's conversation. Dr. Ramirez will highlight how primary care supports vaccination across the lifespan and across the household, and how systems, level access language, and workflow decisions directly impact vaccine uptake in the Latino community. So Dr. Ramirez, I will turn it over to you now.
Thank you so much, Indira, and hello, everyone. So some of my talk will feel a little bit repetitive. I'm not going to go into as much detail as Dr. Ramirez Khan, shared name, Tocaya, but you have a foundation to go off on. So I'll tell you that I often call myself a unicorn family physician. And the reason I say that is because I am a family doc. I do all of the things in family medicine, but that also includes obstetrics. So I am surgically trained in obstetrics, hence why I hold an associate's professor of OBGYN as well as an FCM. And I manage, moderate to higher risk pregnancies. And so I have kind of that whole family perspective. And I also do home visits from time to time. So talk about old school family doc. And I often say that for me, family medicine is the most Latino profession or specialty I could have chosen, right? Because I am so, I feel like these patients and the multinuclei of the patient cohorts I have the privilege of caring for are like my family. And I feel like those of us that are in this space have a unique opportunity to help and not only educate familias or families around vaccinations, but truly address whatever is going on behind the scenes that might be, as you've heard already, contributing to their hesitancy for becoming vaccinated. Next slide. Oh, okay. So I won't bore you with reading you the list, but in full disclosure, I do a few things, but I am not compensated with the exception of my day job here at Penn State for the other things that I do. And so I don't have a financial relationship to disclose. Next. And so I really wanted to give us a perspective, really looking through it through the equity lens. So in my clinic, missed vaccines rarely start with hesitancy, truly in the true essence of the word. I call myself a behind the scenes kind of doc. There's a reason. There's something going on behind the scenes that is then translated as this perceived hesitancy or whatever it is that we're going to call it. And they really start with missed opportunities, I would argue. The sad reality is that a quarter of Hispanic adults are uninsured. We know this. More than 60% are limited in their English proficiency, and a little shy of 20% are actually up to date with their age appropriate vaccinations. So there's more than 80% opportunity for us to impact change. But that change can only happen if we're willing and brave enough to go behind the scenes and understand what's going on. So if you don't have usual source of care, you don't get that reminder call. So I don't know about your offices, but we offer a reminder call or a text. Well, if you don't have usual source of care, if in the EMR, your language, because of false fluency, was recorded as English, and yet you speak Spanish, it doesn't matter that you got the call or the text if it's in English, right? So there's a missed opportunity. If you don't get the answers in your language, you don't get to do shared decision making. And I don't know about you, but there have been a couple times where I've had to interrupt the translator iPad or interpreter iPad because the way the information is being interpreted is not the most accurate. And I get a window into that when I have a student with me who I still have used the interpreter. I think it's important for their identity formation as a future physician to go through the motions of using an interpreter. So I just stand in the room like a fly on the wall, and goodness, thank God I can do that, because I have discovered that, Spanish is not a homogeneous language, right? So depending on the country of origin, you have different, even the same country, I would argue different neighborhoods might use a different word. And so, they don't have that opportunity to be involved in the shared decision making that we often talk about and we teach. And if vaccines aren't available where they already are, the default becomes delay, right? So if I can't get to that pharmacy because I'm in rural America or don't have a car, or don't have the money to put the gas in the car, I'm not going to get there. And so hesitancy, there's more going on. Next slide. Okay. So because I take care of pregnant people, I don't have one patient. I have two for the price of one, or sometimes three if they have twins for the price of one. Beyond two, I transfer to maternal fetal medicine if they have triplets. But if, so there's not just one patient. So as we already heard, vaccination in pregnancy doesn't just protect that individual you're seeing. And so I often frame it for my patients that I'm vaccinating you as a vehicle to protect your baby, even before a baby is born. And really pause there for them, because often the pregnant individual may not be thinking about it that way. Like, oh, you're giving it to me, but it's for me, but not really for me, but for the baby. How does that work? And so it's important to understand. And then when we look at the rates of vaccination, we're not doing that great. When we look at flu, less than 50%, this is the 23-24 season. Tdap a little better, but overall, not the best. Then as a reminder, flu vaccine that can be given any trimester, Tdap every pregnancy. That's the key. RSV, as we heard, 32, 36 window. And why do we stop at 36? So the thought is that really to have robust immunity, you want to have it on board about 2 weeks before that baby is born. And so if we administer at 36, if the individual delivers at 38 or beyond, that infant will have some protection. We heard about the COVID-19, but the other one to consider is a hepatitis B vaccine. So, in my office, I am checking to see if you're immune. And if not, then we're having a conversation about the risks of not being immunized to that infant, to themselves, and the opportunity that we have. So I have the privilege that I see them every single visit. I've been here so long now that delivered more than one. So I see them even before they're thinking about becoming pregnant, when they're thinking about becoming pregnant, every visit, deliver them, and then after. So as soon as I see them that first, second visit, I'm checking to see if they're hepatitis B immune. And if they're not, we're talking about, well, we can get it done, before you have the baby. And what does that look like? And are you comfortable with that, et cetera? But it is a lot of vaccines. And so, it's really about having those conversations. Next slide. So, small gaps, as we're familiar with what's going on in the news, creates a risk for outbreak. So by age 2, coverage still remains low, below the healthy people targets, and it's lower for Hispanic people as compared to white children. And what are some of the barriers? So if we think about 80% of what impacts that individual's life is the environment that they live, right? So the thing called social determinants of health, access to food and shelter, safety of that neighborhood, your support system, transportation, access to education, and all of those things. So only 20% of what I do in this office where I am right now has anything to do with having a meaningful impact long-term for that individual when I have them in my office. It's 80%, up to 80%, that truly is what, makes it all go awry or succeed or whatever it is. And so if we don't take the time to better understand that 80%, it doesn't matter that you're physician of the year or that you're nurse practitioner of the year, or that you are an amazing social work case manager, navigator, et cetera. If we are not addressing things, we're not going to move the needle. I'll give you a short story. It's not related to vaccines, but patients have taught me a lot in my career. You have to remain humble if you're going to do this. I remember a patient with asthma. No matter how much I worked to get her asthma under better controlled, whether it increased the doses of her maintenance inhalers or steroids, etc., nothing I did. And because I do home visits, I said, you know what? I'm going to your house. There's something I don't know. She was doing everything correct. And yet just having one after the other exacerbations, and nothing that I was doing was helping. And I said, let me go to her home. When I go to a patient's home, I always do what I call safety checks. So I look everywhere in the house. I look in the cabinets, in the fridge, in the freezer, in the bathroom, everywhere. Well, when I looked under her kitchen sink, if you were in front of me, I would say, guess what I found? Well, guess what I found? I found a bottle of bleach and a bottle of ammonia. And guess what she was doing just about every day? Not every day, but several times a week. She was cleaning with a mixture of bleach and ammonia. Go figure, right? Mind blown. And so that was for me the aha moment. After I, provided education about the harmful effects of using these toxins, then I understood this was the reason for why her asthma kept being triggered. And once we stopped using these, she also had many plugins and burnt candles. And so that home visit took a while. Well, once I was able to help her eliminate these triggers from her environment, her asthma became so well controlled that she just needed an albuterol inhaler once in a while. And so I tell you this story to highlight and illustrate for you The non-adherence, the non-compliance, the hesitancy in front of you, they don't want to talk to me about this, is a symptom of something bigger. So be brave to go behind the scenes. Next slide. So as you've heard, HPV vaccine prevents cancer. So when I am talking to families, I start at 9 years old, actually, encouraging or having the conversation about vaccination. I pose it as a, cancer prevention tool. And, later get into the conversation, should they ask about, sexual transmission and things like that. And, I think that it's important to try to, normalize the conversation as you are introducing other vaccines that we often do between 9 and 12, tetanus, Tdap, and meningococcal, and also we can start the HPV vaccine today. And, your child can get one today. And in 6 or 12 months, we can do second one and then they'll be done. And allow the conversation to evolve from there. Next slide. So after 18, the gap gets wider. So adult vaccinations is where you truly start to see the inequities that exist, because it depends really right on insurance, usual source of care, and having repeated touch points. So when children are young, you're seeing them perhaps more often, and I believe every visit is the opportunity to get a vaccine. My patients joke with me, "You're not going to poke with me today." I'm like, well, let me check. Are you due for a vaccine? Whether it's for a cold, and I also provide education about that. You can get vaccines, every touch point, because, I care for very socially and medically complex patients. I don't know when I'm going to see them again. I don't know when they're going to have to live somewhere else. Just today, I was seeing one of my highest risk OB patients, and we were talking about the location she's currently at because her home, the pipes froze. So she had to quickly find somewhere else to go. So the location where they call home might change, phone number might change, all kinds of things. And so when you have them in front of you, it's just an opportunity. So, when we think about Tdap in the last 10 years, for example, about 20% in the Latino community are up to date. So whether it's no one offered it or did we offer it, but in a language that they didn't understand, did we do such a good job in talking about it in pregnancy that they're convinced now it's only in pregnancy? Do they even have insurance and can't afford it? All real things. Okay, next slide. And so, when we think about hospitalization and readmission rates and things like that, really, preventing hospitalization is really, we're talking about preventing inequity. There are times where, our patients end up in the ER or the hospital, not necessarily for reasons simply because they didn't have access, right? So they didn't have the access issues, or they had the access issues I described, so they were unable to become vaccinated and hence became ill with RSV or pneumonia or flu or COVID. And that is going to impart a higher morbidity on their health. And so again, I just trying to hammer it in there where we have to think about the social burden. Think about co-administering vaccines. We know that co-administering flu, COVID, Prevnar, pneumococcal, or it's safe. It's okay to do. I think that as was highlighted earlier, I normalize side effects. I say, side effects of vaccines are the same. I talk about the fact that if you have elevated temperature, it's not a fever like you're sick. It's your immune system is doing what it's supposed to do. And oh, by the way, when your temperature goes up, the body slows down and you might get achy. But guess what? In 24 to 38 hours, you're going to be fine. You're going to be okay. And not everyone gets those side effects. Pause and talk about, what is their concern around that. Next slide. Yeah, so making it normal, making the vaccination default, right? It's part of your routine conversation. They know every time they're coming to you, you're going to be talking about it. Do you have opportunities for standing orders versus nurse only visits? You know, do you have bilingual scripts or materials framing HPV as a cancer prevention tool? Do you have partnerships with pharmacies within the neighborhoods? Have you empowered your, barbershops, your beauticians to talk about vaccines? There's some evidence that that's very effective. Next slide. Okay. So, 3 levels as we talked about to close the gap for Latino communities. Think about the barriers related to being uninsured. Think about language access. Think about vaccines to where life happens. Life doesn't happen in our clinic. It happens at the barbershop. It happens at the beauty salon. It happens at the restaurant. It happens, in the mobile clinics or pharmacies. That's where life happens. So bring things there, partner with these organizations. Next slide. And that's it. And so this is me here administering a COVID-19 vaccine to a community partner at the time during a mobile clinic vaccination clinic. And so vaccination event. We were out during the height of COVID-19 in a mobile unit, traveling around Pennsylvania, driving right into the most impoverished neighborhoods of the state, talking to people at the bodega, at the restaurant, wherever we could find them, and going to their door because often they can't come to yours for whatever the access barrier is. So thank you for listening to me. I'm happy to be here amongst all these amazing people. And that's all I have.
Thank you so much, Dr. Ramirez, for grounding the discussion in the real world primary care practice and for reminding us the importance of those social determinants of health. So our final speaker is Dr. Eduardo Sanchez, who will be providing a policy and symptoms level perspective. Dr. Sanchez will discuss how vaccination intersects with chronic disease prevention, as well as equity. So thank you, Dr. Sanchez. And now I will turn it over to you.
Buenas tardes. Such a pleasure to be with all of y'all. I'm going to compliment what's been said. The presenters have all been amazing. The Doctors Ramirez and Dr. Soler. So there's 4 points that I'm going to make. Let's go to the next slide. But first, I am a family physician by training. I am also a public health physician by training, and so I'm a different kind of unicorn. But I bring a different perspective. I work for an organization that has a great vision and mission statement, advancing health and hope for everyone everywhere, and to be a relentless force for a world of longer, healthier lives. So if you're wondering why is somebody from the American Heart Association talking about vaccines, I would just say, look at our vision, look at our mission. Whatever we can do to extend life and health, we are interested in doing. And I will make the case that there's good reason to be thinking about vaccines. 4 points that I want to make. 1, childhood vaccines are safe and effective, as we heard. They protect children, families, and communities. And what's really important there is that when children are vaccinated, abuelita and abuelito are less likely to get infected. 2, adult vaccines, flu and COVID in particular, but RSV for those over age 75 and for those 50 to 74 who have risk factors, prevent infections. They prevent major heart and brain events. I'm talking about heart attacks and strokes. Adults who get flu or COVID have a higher likelihood of having those kinds of events. Adult vaccines prevent hospitalization and complicated hospitalization, that is time in the intensive care unit. They prevent deaths. And as we heard earlier, they prevent outbreaks, because when too many people are not vaccinated, you can have spread and growth. 3, the divergent messages that we are getting. And I can't figure out the right kind way to say that there is messaging going on from government agencies that is divergent from the messages that is entirely science-based from all of the organizations that are represented here. The American College of Obstetrics and Gynecology, the American Academy of Family Physicians, the American Heart Association, I'd say the American Academy of Pediatrics. Those divergent messages confuse people. They create a sense that there's controversy. And I hope all of us agree there's no controversy. There's just wrong information being provided to people. And they paralyze people. So with confusion and a sense of controversy, people are afraid to take an act, even though the science supports the things that we've been talking about. And the last thing that I think we touched on a little bit, the atmosphere of fear that exists in too many of our communities for too many of our people are keeping them at home. And when they're at home, their ability to access care, their ability to be seen, our ability to provide them vaccines and other medical care is compromised. So next slide. So vaccination rates are not what they could be. They're pretty good for everything that's on this chart, except for flu vaccines. And for me, that's just the message. Vaccines work. The glass is more than half full, but the glass should be completely full. These are things where we should be at 95% on every single one of these, and flu vaccine in particular for the reasons I stated earlier. Next slide, please. Case cannot be more strongly made that vaccines have a benefit to society, and they have a medical benefit, a medical cost benefit as well. Next slide. I mentioned earlier that adult vaccines are really important, but just look at this slide and it's just disheartening is the best word. If 50% is only halfway, we're not even halfway on any of the vaccines, at least according to the data that I'm showing you on this slide. And I do want you to see the column that has Latino adults vaccinated. There is an opportunity to do better. Dr. Sara Ramirez, I think, talked about some important points of why some of the Latino statistics may be what they are. Lower insurance rates, language barriers, and then just misperception of the value proposition of vaccine. Next slide, please. I'm not making this up, and we're not making this up. Among the 10 greatest public health achievements in 2023 or in 2010, vaccine preventable diseases was considered the top greatest public health achievement. And if you look at the 10 greatest public health achievements of the century, 1900 to 2000, vaccine preventable diseases and administration of vaccines is at the top of that list. I chaired a long time ago the National Commission on Prevention Priorities, and childhood vaccines in particular, cost-effective and absolutely impactful from a health perspective. Next slide. So we have a challenge, and some of this has been talked about, and I put new information here. I think I would just call it divergent information that conflicts with what the professional and science and research organizations are saying about vaccines. We're saying the science says these work. We're saying the experience we've had over 100 years are that vaccines work. The experiences that we've had as clinicians when new vaccines get introduced is that the vaccines work, and that the adverse effects are they're low in comparison to the contrary, which is getting infected and having the consequences that come from infections. So during COVID, we at the American Heart Association talked about the 4 M's. Message matters, messenger matters, The means of communications matter. For some, it's the radio and the television. For others, it's social media. And meeting people where they are is critically important. Dr. Ramirez, you made that point. I saw the other point about meeting people at home for homebound seniors. And I would say to you that in this time of fear that exists, we may need to extend the visiting people at home to those who are afraid to leave their homes. And I don't know about y'all, this time around, I'm not seeing patients, but I was in Austin, Texas as a provider when ICE was doing what was now known as ICE was doing raids. And I could feel the fear among my patients who braved the circumstances to come see their doctor. So we learned that all four of those things matter. The message is what to say. The messenger is who is saying it. The means of communication is how to deliver it. And the meeting people where they are is exactly that, getting to where they are, being able to have those conversations that a trusted partner can have. Next slide. These were messages of trying to overcome an atmosphere of fear, that getting vaccinated is really important. But if there's an outbreak, if there are infections going on in your community, whether it's measles or flu, sometimes wearing a mask is the smart thing to do if you're in a crowd. Washing your hands is always the right thing to do whenever you can. And watching your distance is at least a thing to keep in mind as you are navigating spaces where there are lots of people. Next slide, please. Some key takeaways. Obviously, get vaccinated. Get vaccinated. Find ways. We need to find ways to get vaccines into our patients' arms and or thighs if they're children. And that may mean changing the way where we're meeting them where they are. For your questions, the answers should come from your doctor, nurse practitioner, physician associate, local health department, or pharmacy. They are generally following the science of the professional organizations. They are generally people who have established relationships with their patients, like the doctors Ramirez. And lastly, because it is so important for persons with chronic diseases to get vaccinated to prevent a bad outcome. Not only get vaccinated, stay on your prescribed medications. And if for any reason you are running low, call your provider. Try to figure out the way that you can get those vaccines. Vaccines protect adults, they protect their families, and they protect communities. So I think that's it.
Wonderful. Thank you so much, Dr. Sanchez, for connecting policy, prevention, and equity so clearly. And so now we'll be moving on to our audience Q&A. Thank you to those of you who have submitted questions already. So let me start with one that has quite a few questions than just one. So oddly enough, today there was a Senate confirmation hearing for the U.S. Surgeon General candidate, Dr. Casey Means. And so an audience member would like to know if anyone would like to provide comments on a couple of the following topics that were covered during the confirmation hearing. And one is the increasing hepatitis V vaccination numbers. And then as well as the including rising cases in Hawaii and other populations. And then another question is your thoughts on the use of shared clinical decision making, which has become kind of like a buzz term used nowadays, and the associated responsibility and the time of burden shift into clinicians regarding vaccines and other interventions. So happy to let any of you take it away. Get us started with answering those questions.
Jump in. Oh, great. No, go for it. Please.
Well, I'm going to choose the final question of those questions. So I'll give it all to you, Dr. Sanchez, for the others. So, I think the shared decision making, yeah, it's a catchy term, but truly what it means, it's really um, understanding the root cause of the individual's concerns, whether it be hesitancy, decline, wanting to decline it, being uncertain, being afraid. It's only then that you can truly have an informed conversation. And of course, making sure that they understand. And so often I will use the teach back method. So after I give my spiel, I ask, so what are your thoughts about, I'll pick on a vaccine, the flu vaccine. So what are your thoughts about the rising temperature? What does that mean? And I try to match it to their level of literacy, their level of schooling, because literacy is not just schooling, right? It's really literacy around health as well, and whatever misconceptions or cultural beliefs they may hold true due to whatever culture they belong to. The other thing that I didn't mention that's truly important is we assume too often that patients can read and that they can write. And so we say, oh, great, I'm a native Latina. I spoke English later. I'm a certified interpreter, whatever. They speak Spanish. I spoke to them in Spanish. They told me what I said back to me. They understand. And then what do? We give them paper. And we're assuming they can read it, right? And what happens when you leave the office? You forget most of the things that you just talked about and you rely on that paper. But if they can't read, so sometimes I'll have to go on Google Images and print a sun for day, a moon for night, a fire truck for albuterol, rescue. And so do we truly understand the level of literacy for that individual that's looking at you? So shared decision making is all about that. It's really truly meeting people where they are, but you got to take the time to understand where they are. So that's all I have for that. So Dr. Sanchez, feel free to take the other two bullets.
I'll just add a little bit. I think that on the shared decision making, again, those are fancy words. It's nothing more than sitting down and having a conversation with somebody and determining what's the best next step based on the information that people understand and that they can use to make an informed decision. I came across, I'm a big fan of motivational interviewing, sometimes known as nudging. At least that's the word I would use. And there's kind of a 4-step motivational interviewing. I think these are words that we can all understand. Establish or have established a safe, trusting relationship. It's kind of hard to do shared decision making if there isn't some sort of a relationship there. And so those who have a relationship with patients can build on those. Understand people's concerns, and more important, listen without necessarily responding to all concerns. Listen, take it in, understand where they're coming from. 3, offer information in what I call weekend language. Let's not use the language that we use, shared decision making, not good language. Let's use the language that we use with our families when we're around the table on a Sunday with abuelita, abuelito, and our cousins. And then 4th, the really important one here is to validate an individual's decision-making autonomy. It's your decision to make. I can help if you would like in terms of providing you information. And oh, by the way, you can say no. It is okay to say no. That's another thing to validate. I think that as it relates to the increasing numbers of cases of anything, I would just say one of the things we talked about is missed opportunities, not vaccinating people and not finding every way to make it easier for people to get vaccinated rather than more difficult. I don't disagree that we should have conversations with our physicians, but Dr. Sara Ramirez talked about what I would call the missed opportunities. When it doesn't happen now and it has to happen tomorrow, you just miss the opportunity to do a thing that the evidence says works. And so it's disheartening that the person who's going to be Surgeon General might be somebody who is creating more opportunity for missed opportunities, which will increase the exposure of people at risk of having bad things happen if they're infected. It's all one can say. It's disheartening.
And if I may add one quick thing, I'm sorry, I'm chatty here. The other thing I'll say that's so important to trust building is that my goal is never to get to a yes. The way you break trust is if you are too forceful about your agenda. My agenda as a physician, obviously, is I want them to say yes to become vaccinated. But for me, I understand that to get to a yes one day or maybe today, I have to build trust. I have to engage with them on a level that makes them believe that I truly care about their health and what is best for them. And so a no today is not a no forever. I have learned that through the years. A no today, but they are willing to sit there for 10 minutes and have a conversation is a little crack in the door. And maybe next month in the follow-up, you talk about it again, the door opens a little more, it might be another no. And maybe the fifth visit, they'll say yes. That's a win. And so I think sometimes as providers, we have to readjust our expectations and redefine what success truly means. It isn't about, you're going to believe me today, you're going to say yes today, great, vaccinations go up. It's over time. And what happens? You build trust on this one thing. It's an entry point to care and to improve outcomes across the spectrum.
Yeah, no, thank you for that wonderful reminder, Dr. Ramirez. In the interest of time, might ask one or two more questions. This next one is also someone in the audience, and actually, Dr. Ramirez, you alluded to this when you gave your anecdote about the home visit. So they said lots of talk about visiting patients at home. Would love to know if that's where the industry is going, especially with a large retiring generation preferring at-home care.
I don't know about the industry, but what I do know is it was very integral to my residency training and where I did fellowship. So it's become just a normal part of my practice. I don't do it for every patient. It's truly based on a need. I've done home visits to provide wound care, but I've also done home visits when I got a call that, an elderly patient was, terminal in her disease, stopped eating. I knew we had days, right? So I went and did a philosophy of care visit. So truly it's about what's needed, and it's not about every patient going to their home. And I don't know what the industry, but I do think it's important we owe it to patients and the community to understand what their barriers are. And I've even done a home visit for an undocumented pregnant individual because I was scared. I was more scared than she was. And I said, you're not coming in my office. I'm going to your house, right? Because I didn't want her coming here. I was so scared. So it just depends for me individually.
For OBGYN care, specifically postpartum care, postpartum is a really vulnerable time where patients are unable to get to the office, right? They have newborn, they had childcare issues. So it's an area where we call it the fourth trimester, and it's the time where where a woman is at highest risk of developing a lot of comorbidities. So interestingly, some health insurances are actually including a nursing home visit to check blood pressure. So patients who are at increased risk of preeclampsia, eclampsia. So that started off in Europe, and those models were really, really positive. Those nurses can also help with lactation. They can also kind of serve as lactation consultants. So it's really, to your point, Dr. Sanchez and Dr. Ramirez, about missed opportunities. It's a way to really capture those events. So I can't speak to all specialties, but I can say some specialties, especially some circuits, and employing our NPs, PAs, as we see more of them in our workforce, these are really wonderful avenues where we can potentially make a big difference in patients' lives to be able to access them in their home, and we can remove some of these social determinants to health.
I'll just add that the industry is moving in that direction in some ways with the growing awareness of the opportunity of extending care from the four walls of clinical settings into communities and into people's homes. So the answer about bringing it directly into communities, absolutely, we should have mixed ways of doing things. It's ways to build trust. It's ways to build relationships. It's ways to have messengers delivering messages. But community health workers, promotores, can do the sort of thing that Dr. Ramirez was talking about. I guess we trained in similarly high-minded places where home visits were part of what I did. And I actually believe all training should involve some degree of home visits so that you begin to understand the value. My gosh, doing a social determinants of health assessment on a piece of paper, that may be good, but going to someone's home and seeing what's going on, that's even, and the neighborhood that people live in, and understanding, that's even better. Dr. Soler, I'm so sorry, I cut you off.
No, I agree with you. But also I think going maybe to places where people are used to go and trust also is very important. And like as I mentioned, the consulates where people are more used to go, or the community center that they assist, or places, for example, in the college students, we do our work, some of the work that we do in universities, going to the places that people are used to go and already trust. That helps have a more confident on vaccines.
Thank you, Dr. Soler. And we'll move on to our last question, just closing thoughts from each of you. So what advice would you give providers who have joined us today on the immediate action they can take, not just this week, but going forward to better support their patients during this respiratory season?
Well, for me, I think doing more target-oriented messaging, looking very closely to the population we are working with. The fact, as Dr. Ramirez mentioned, many people may not know how to read, or they are not confident with reading. So using materials that are more pictures or more graphic, the language that we use, and trying to connect with that person. I think that would be my suggestion. And I think that in our experience that works very well.
We had to bring back masks in our hospital down in Atlanta because of the uptick in flu cases, and that was a wonderful opportunity for me to speak to patients, all patients. So we were wearing masks, and I said, "Oh no, now we have to wear masks mandatory because of all the rising cases in flu. Have you been vaccinated for the flu this year? If you haven't, I would strongly consider it." Right? So different ways of doing this, especially RSV as well for those high risk patients, COVID, and letting people know that it's even if you haven't yet, there's still an opportunity. In Georgia, there was a brief period where we needed to have for COVID. I know this happened in other states. You needed to have a doctor's note, a doctor's prescription. I was handing those out like water. I was like, "Oh, did you get your COVID vaccine? Oh, you haven't yet? Let me write you a prescription for it." Right. So being able to kind of normalize it. I think in somebody's slides it mentioned this, that actually, Ramirez, you said that basically saying, "Oh, for the HPV vaccine," I think is, "Oh, today you're due for your HPV vaccine," right? It was more of a, "You're due for this today," almost like, this is what we do, this is the standard, this is exactly what we want to ensure that you have. And I presented in that way that, "Oh yeah, we get the flu vaccine, that's what we do." Could that be considered coercion? Absolutely, right? Like, so we have to also be mindful not to coerce patients to do things. But then if they have questions, that invites the conversation. "Have you gotten it yet?" "Oh, why not?" Right? And it inquires into what reasons, what barriers there may be.
I think the other part too is as providers and community workers and things, we need to be creative about using what's available in terms of what's in the news to help us in education. For example, I don't know about your areas, but for me, there's a city called Lancaster, which is about 30-45 minutes away from the city of Harrisburg, where I see patients. Well, there's a measles outbreak. And so I use that as an opportunity to provide education. And so I talk about, I don't say, "Did you get the vaccine?" I don't start there. I start with, "Do you know what measles is? Have you heard about the outbreak? What are your thoughts about it? Does it make you concerned?" Blah, blah, blah. And say, "Hey, by the way, you can avoid some of that or decrease the risk if you consider this vaccine." And, because part of what I'm seeing, I don't know about everyone in the audience, is we don't, it's like diabetes, right? We don't take the medication, we don't take the vaccine because we feel fine. Or I don't see measles, I don't see polio. Like, why that doesn't exist? It doesn't affect me. So, like diabetes, you don't feel diabetes, so it might be too late, right? It's already caused damage. And so I think that there's a lot of that too. I'm fine. We don't have polio, so why do I need a polio vaccine? And so the MMR outbreak provides us with an opportunity. The other thing since I care for so many children, RSV, I have many families with kids in daycare. The kids are getting RSV, the parents are missing work, and I say, hey, remember RSV? You got that last year. Well, we now have a vaccine. And so being creative, I think using the information that's available can be helpful.
Thank you. Dr. Sanchez, do you have 10 seconds of last
Seconds. Contextualize, normalize vaccines. I think we've heard, and find the thing that works in the setting that you're in. I will say telling stories and exposing your own story. During COVID, one of the messages that I found really effective is, my mother's vaccinated. Yo duermo mejor. I sleep better because my mother's vaccinated. I think was a stronger message than anything that I could say, because my mother was an old lady. She got vaccinated. I'm comfortable with it. It worked. And I don't know if it's coercion or nudging. And so I just say, let's not use the word coerce because that sounds bad. Let's use the word nudge, shared decision-making, motivational interviewing, because one could argue they're the other side of that same coin. So and normalizing, I think is really important. And however we do it, that we are consistently asking about vaccines, almost year round, but definitely during respiratory season is really important. Let's start in September and just keep it up. And thank you for the opportunity to be with y'all and to be with this esteemed panel of health professionals.
Well said, well said. Thank you so much, Dr. Sanchez, and to all of our speakers today. And thank you to those of you who asked questions. I know we are at time, but if you will allow me just 2 minutes for some closing thoughts. I wanted to share a few upcoming NHMA events and opportunities for continued engagement. So similar to this one, NHMA hosts regular town halls and webinars and educational programs that are focused on public health policy and advancing health equity in our communities. And so we encourage everyone to go visit our website and stay connected to learn more about upcoming events. And we also invite you to stay connected with NHMA on social media. We are, I think, on most of the platforms. So by following us, you can stay up to date on our upcoming events and resources, as well as public health information. And so you're also welcome to tag us and share information about our town hall today using @NHMAMD. And then we also want to highlight HispanicHealth.info, which is NHMA's bilingual resource hub. And so this platform offers trusted and culturally relevant information in both English and Spanish on a wide range of topics, including vaccination and chronic disease prevention, as well as maternal health. And so we encourage you to explore the site and share it with your patients, families, and just anyone in your community. And if you are a healthcare professional or a community leader and you're interested in supporting NHMA's mission, we invite you to become a member. Membership includes, membership helps support our work in advocacy, education, leadership development, and advancing health equity. And I'm biased because I lead our policy and advocacy portfolio. So I encourage you all to get involved with NHMA so that we can work together. And so you can learn more about our membership opportunities on our website. And lastly, I wanted to highlight another valuable resource that we have, which is our job board. So whether you're seeking your next career move and looking to recruit top talent, so this platform connects job seekers to active employers and features a lot of job openings. So you can feel free to scan the QR code there on your screen and visit our website to explore more opportunities and connect with others in our network. And so thank you all so much for joining us today and our speakers again. We appreciate you all taking the time and staying engaged. And we look forward to seeing you at the next webinar. So
thank you so much.
Thank you.
My pleasure.